Health. So nice to meet you. I'd like to introduce Dr. Shane Amahani is a pulmonary and critical care physician and the medical director for the Swedish First Hill Medical ICU. And he's here today to talk about sepsis and give an update. I'm making a mistake with all my screen shares here. I'm going to stop screen sharing. This is just our financial disclosures. I will put the CME information in the chat a few times. And if you could please also include your first and last name in the chat, as well as your credentials, so I can send that in for CME credit. All right. It's all you.
Okay, thanks, Sarah. And thanks to all of you for coming to discuss sepsis today. Can you hear me okay and see my slides?
I can.
Great. Okay. Well, I'm going to give an overview of where we are with sepsis in 2022. Discuss some controversies with regard to the Step 1 mandate from CMS and the new guidelines that were published last year from the Surviving Sepsis campaign, and some other things along the way. Let me see if I can advance slides here. I have no conflict of interest to disclose. I am a site PI at Swedish Medical Center for doing research in acute lung injury, sepsis, and in the last couple of years, COVID as well. Here are some key takeaways that you can hang on to if you have to leave or doze. Step 1 may not improve outcomes according to some recent studies that we'll review, but we still have to fill out the reports, and every hospital is responsible for getting them in. Updated guidelines are available as of last year, and a lot of the quality of data remains low, but these do present a standard of care. Early antibiotics for septic shock is being highlighted, whereas to reduce excessive antibiotic use, they're encouraging hesitation with mere possible sepsis. Novel diagnostic tools, there are many of them in development, but they're not ready for prime time. And there are many questions that remain regarding how much fluids, what type of fluids, and we'll dive into that. A key to improvement that I'll stress is a progressive attitude to failure. All right. So the word sepsis comes from the ancient Greeks. It was in Homer. It means something to do with to rot. And this was a comment made by a physician or healthcare person at the time of Hippocrates. A local lesion heated by humor afflux makes the whole body become feverish. One can die because of this, especially on odd-numbered days. And this is very prescient because it still fits our paradigm of what sepsis is. Something starts an exuberant inflammatory response, the humor afflux. It becomes systemic, the whole body becomes feverish, and it can be very morbid and mortal. And there's something to do with timing. They might not have gotten it right back then. In a modern day build of the physiology of sepsis, of course, we have the same processes. There's massive immune response, organ injury, and hemodynamic collapse. When we look down on a cellular level, we have learned about a lot of things that are potential places to intervene, but also just to be aware of so much of what our immune system does to fight microbes. And I put this in there because I think it's really cool. These are neutrophil extracellular traps, a function of neutrophils that wasn't known until the last 10 to 15 years. Neutrophils essentially can condense their nucleolar component, histones and chromatin and DNA, and eject it into the environment around them, trapping organisms, signaling to other cells. It's known for many infections now, but it's also being seen in a growing number of immune-mediated conditions. So we'll learn more about this, I think, in the years to come. We also know sepsis, of course, on the social level as something that is common, morbid, and very costly. It's a leading cause of hospital deaths and a leading cause of cost for the healthcare system and hospital cost for death. And part of the costs include fulfilling, government mandated care, including SEP1. And we know the rates of sepsis have been increasing over time, and the rates of survivors have been going up with that. And there's great morbidity associated with having sepsis for the survivors. This was a population study done by Jack Washington and others from Michigan that followed a population of patients through several health events not foreseen. So patients who went on to have sepsis, they looked at them in the years afterwards to see if they had changes in their cognition, changes in their functional capacity. And they showed that the percentage of patients with moderate to severe cognitive impairment increased in the period after sepsis and lasted out to 3 years. Similarly, with functional disabilities, there were now, in the period after having sepsis, persons even without any disabilities tended to have 1 or 2 disabilities, and in this study, out to 5 years. So the costs of sepsis are high, even after survival. And we see sepsis from the hospital perspective, where we have a goal to deliver patient-centered, high-value care. In this model, a lot of interest has been focused on the 3-hour bundle and what we do up front, but really we're tasked to accomplish all of these goals: resource utilization, perfect care, patient experience throughout the hospitalization. Clinicians at the bedside, sepsis is an emergency, and sepsis needs to be dealt with quickly. I'm going to go through a case that has been a touchstone for me when thinking about improvements in sepsis care and highlighting where some of our recommendations have changed over time, as well as the emergency and the risks of sepsis. Sam was a 38-year-old female who had asplenia after a motor vehicle accident early in her life. She delivered 8 weeks earlier her second child. Over a couple of days prior to coming into the emergency department, she had pain in several muscle groups in her body, in her legs and shoulder area. And on the following day, she developed lethargy and fainting and was brought into the emergency department. She had tachycardia, low blood pressure, and tachypnea. And at this point, certainly infection is on the differential, but other things, pulmonary embolism, cardiomyopathies, and others would have been there. But this is a sepsis talk. She went on to have a high temperature. She had leukocytosis and elevated lactate. So at this point, as you all know, we would want to give antibiotics, check blood cultures, give fluids, and she certainly received fluids, the 30 cc bolus and more. And she had continued hypotension, went on to receive even more fluids, subsequently developed fairly severe hypoxemia, and went on to have ARDS requiring neuromuscular blockade, prone positioning. And while that's somewhat commonplace now in the time of the COVID pandemic, we weren't doing it all that often for patients coming in without a direct hit to their lungs, but she certainly was at high risk of dying. She had a sepsis cardiomyopathy and acute kidney injury. She spent 15 days in the hospital, and then was out of work for months, recovering. She had a couple of other things that kept her out of work, I'm sure, but the severity of her illness certainly required a prolonged recovery. She turned out to have a strep pneumonia and bacteremia and pyomyositis. Her muscle groups were evaluated, there was infection, but she didn't require any surgical intervention. And her risk factors, of course, she had asplenia, putting her at risk for this organism, pneumococcus. And she had, in the postpartum period, it turns out there is an increased risk for having invasive streptococcal, group A strep, group B strep, and pneumococcus invasive infection. So she survived, and she thanks us. We were very thankful that we were able to support her through this. But should we count it as a pure success? And the reason I've held on to this case is that actually we didn't do everything perfectly. And perhaps things could have gone better for her if some other things had happened, including giving antibiotics earlier in the course. She actually didn't receive antibiotics until between 3.5, 4 hours. And then there's been questions about which fluids are better, saline versus lactated ringers. How much fluid should she receive? She developed ARDS. Was that organ injury partly a result of the excess fluids she received early on? And other questions about steroids, vasopressors, all of these have been part of questions in sepsis, and I'll touch on them as we review the Surviving Sepsis Campaign update. And the big question many of you might have asked is, wasn't she vaccinated for pneumococcus? And that should have been something that happened for her well in advance, and it was taken care of afterward. So a phrase I've taken from a book I recently read by Matthew Syed. The book was Black Box Thinking, in which he describes successes and failures in the healthcare industry, in the airline industry, and in judicial crimes. I'm forgetting the exact word there, but the phrase is, a cornerstone to success is a progressive attitude to failure. So looking for not just the success that we had in a case like that, but also where did we not do our best? And this attitude has to be shared by a whole team, an institution, and actually the whole approach to sepsis as a healthcare adventure. And failures can be seen on a big scale. So I'm going to dive into a controversy that's come up in the last year following concerns that many societies had about how SEP1 is performing. And it recalls what happened a decade earlier when CMS had a community-acquired pneumonia core measure, which was put out around 2002. Later in that decade, looking back at the impact of the CMS community-acquired pneumonia measure, there was certainly a change in practice in emergency departments, but the practice led to excess antibiotics without a major improvement in treatment of pneumonia. And that concern is being forwarded now to SEP1, a similar concern. SEP1, before I get any further, in case anybody isn't clear on what it is, in 2013, there was a recommendation to CMS to institute mandated care for sepsis to improve awareness and improve care. And a group called the National Quality Foundation oversaw which items would be part of the sepsis bundle and made the recommendation to CMS, which then started to ask for this data in Q4 of 2015. The data that they're looking for are all process measures, and it's a very complicated request, described as being probably the most complicated mandate request from CMS. The basics were trying to drive the 3-hour bundle, as it's called, getting lactate measured early on, getting blood cultures, giving early antibiotics, getting a fluid resuscitation going, and then if shock is present, having follow-up exams, follow-up lactates. Those are some of the core measures. In this last year, the IDSA, Infectious Disease Society for America, and these other societies from hospital groups, hospital medicine, emergency physicians, pharmacists, wrote a statement with several concerns about the performance of step 1 and the cost that has caused for hospital systems. These concerns include a claim that despite massive investments by U.S. hospitals, step 1 activities have not improved outcomes for patients. And we'll look at the data that they are basing this on. Step 1's requirement to immediately administer antibiotics for possible sepsis risks increasing excessive and unwarranted antibiotic administration. Step 1 conflates the urgency of antibiotic administration for sepsis and septic shock. The current step 1 times 0 is complex, subjective, and not evidence-based, and serial lactate measurements have not been shown to consistently improve clinical outcomes. One of the authors was Chanu Ri, who has been doing a lot of work on the impact of process measures like step 1 on sepsis care. In this study, he had 114 hospitals and 117,000 patients with data spanning the time before and after the introduction of step 1 in Q4 of 2015, and used a clinical definition to identify patients with sepsis, rather than the coding definition that CMS uses to select patients, and for which hospitals will report on. The outcomes they were looking for was the rate of risk-adjusted short-term mortality, and that's mortality in the hospital, including patients who were discharged to a hospice-like setting, or other outcomes were lactate ordering and antibiotics ordering. So the result that you're getting is that there was actually no change in the risk-adjusted short-term mortality for patients with respect to sepsis before and after the introduction of step 1. There was an immediate increase in lactate testing, which suggests that the impact of step 1 was certainly present in terms of behavioral changes, and there was an increase in broad-spectrum antibiotic use, but this trend predated step 1, and they wouldn't make the association being a result of that introduction. When you focus on the patient with septic shock, there was a similar result that for those sicker patients, the introduction of step 1 did not make a change in the mortality rate amongst those 114 institutions, and patients identified again with a clinical definition here for septic shock. One other study from University of Pittsburgh Medical Center, so they're single institution, but 11 hospitals, also used a clinical definition of sepsis spanning the same time period, 2013, 2017, and doing the before and after analysis. And I quote their statement here: the SEP1 program was associated with increases in adherence to individual process measures, showing that pay-for-reporting programs can induce behavior change at the bedside. Increased lactate orders accounted for much of the improved adherence, more than antibiotic fluids, and there was no meaningful change in clinical outcomes. The same group had a couple years earlier reported on a mandate that actually did improve outcomes, and that was the first the first state mandated improvement for sepsis management, some of which the CMS one was built on, and this was in New York State. You may remember the story of Rory Staunton, a 14-year-old who had died with sepsis, which initiated a movement to make more awareness and improve the early care of patients with sepsis. So Rory's regulations went into effect in 2013, and this mandate had some differences from what became the Step 1. Here there was more of a focus on outcomes as well as bundle components, whereas Step 1 focused mainly on completion of components and didn't ask for outcomes of patients, and there was a larger emphasis on education. So the idea here is we see that mandates can impact care at the bedside, but maybe the mandate that we currently have hasn't had an effect because of how it's built, and it may need to be changed. This was part of the recommendation in that IDSA position paper. They made the following statements. They suggested that the bundle should focus on patients who are most likely to benefit from rapid and aggressive interventions, those with septic shock, so the sicker patients. They wanted to minimize antibiotic overuse and adverse effects of antibiotics by eliminating patients with sepsis without shock from the bundle. They wanted to eliminate bundle elements that do not contribute to improved patient outcomes, such as serial lactates, and then streamline the reporting process to focus on clinical outcomes, as was done in New York, and then to really help hospitals and reduce the cost of trying to track down all the information in following through with submission to CMS, digging into EMRs. They wanted to make reporting electronic with data that is easily extractable from the electronic health record. These recommendations were put forward, and apparently there was a meeting where NQF had an opportunity. That was the society that initially made recommendations to CMS, and they had an opportunity to review these ideas and potentially make changes, but the Step 1 was continued as it currently stood. There were some changes over time, as you may know, that the amount of fluids, there's a little bit more leeway with the amount of fluids if it's carefully documented why you're not giving the full amount of fluids. So there have been changes, but more were expected. There's actually an appeal now being sent back to NQS to ask if they could have more time because they were unhappy with how the meeting went from a parliamentary perspective. Sean Townsend, the author of the paper I'm showing up here, is a physician at Sutter Health in California, who has been a leader in supporting Step 1 from the beginning. And you'll see other names up there, like Emmanuel Rivers, who obviously was, if you remember, his initial paper in 2001 on early goal-directed care. He was the lead author in Henry Ford Hospital in Michigan. So the bundle came out of early goal-directed care ideas. Sean Townsend is still supportive of pushing ahead with step one, and he points to this paper, which provides some data that's contrary to the studies I just reported on, which were more focused on looking at the broad population and to see whether there was an improvement in sepsis, looking at clinical diagnosis sepsis after introduction of step one. His study looked at cases that were reported to CMS and looked at which cases had completion of the bundle compared to cases that didn't have completion of the bundle. And it was a propensity matched cohort study. So they tried to match the population and then compare. And in that study, they showed that compliance with the bundle was associated with a reduction in mortality. So this supports the ongoing step one. And I think that I look forward to hearing more about this discussion. I certainly cannot weigh the benefits of this complicated paper versus the others, but able to say that there remains some controversy about individual elements such as lactate. Should we really need to check all these lactates? Is it helpful in all patients? And should we be applying step one to patients who are not in septic shock? Would it be better to focus on septic shock? So I think there'll be more to come on that. Right now, there hasn't been a change, but we may see it in coming time. The Surviving Sepsis Campaign guidelines were also published in the last year, and the update for 2021. And some of the recommendations that came out of that IDSA position paper did make it into the Surviving Sepsis Campaign. And we'll see that especially in the antibiotics section. I'm going to review here these items that you see on the left: screening for sepsis, antibiotics, fluids, vasopressors, and then briefly hypotensive cannula, steroids, and vitamin C, which had updates, changes that are of interest to clinicians. The whole guideline is actually a very good description of great hospital care. They go into depth into many topics that is great patient care. However, as I mentioned earlier, the data for most of it remains, they'll describe it as low or moderate quality, but it is kind of a standard of care. One of their first statements was to point out that QSOFA has been used frequently as a screening tool, whereas when it's been studied after its introduction in 2017, it really hasn't performed well as a screening tool. QSOFA came out with the sepsis 3 definition and became popular to add into tools for fast recognition of sepsis. However, it was not designed for that goal. It does function very well as identifying patients who are at high risk of poor outcome, but these patients aren't necessarily just sepsis patients. So its place should not be as a screening tool for sepsis in particular, and the other ones mentioned there, SIRS, NEWS, and MUSE, perform better. There's not a lot of other new material in the Surviving Sepsis Campaign about screening and identifying sepsis, but there's been a ton in that realm in the literature and many proposed ideas. It is somewhat of a holy grail, and I'm just going to highlight a couple of things that have popped up in recent years here. Pre-hospital can be important. There are novel diagnostic tools and more use of artificial intelligence. So I think there's going to be many holy grails that they'll find. I found this one on Etsy, if you're interested. Not just one holy grail. The community awareness is important, and this is probably something we should be doing everywhere, as helping communities understand what sepsis is, when they should be concerned about someone, and that it does constitute an emergency. This is a handout from one of the Providence hospitals in California that they give to patients going home after surgery or other procedure. And it's an easy tool for patients to help think through when they should be concerned about their loved ones. There are tools that may be used in the home in the future, and some of you may recognize this. I'm not endorsing it, I should say, but I think it's a step into the future. This is the Q, an at-home molecular test, and this was first sold as a test for COVID, and you can still get it. So these cartridges actually run PCR tests, which you can buy the unit, buy multiple cartridges, and run the test. They're proposing to have a whole array of microorganisms for their testing and other conditions. They'll have a pregnancy test, and they'll have potentially in the future tests for our inflammatory state, or something that could help raise awareness of when a patient might need to seek help. That's down the line in the future. Things that are closer at hand are improved laboratory techniques that can get the diagnosis of which organism and presence of sepsis much faster than tools that we have now. They highlighted in this diagram the critical time period of 3 hours, and showed as a comparison to blood culture there in the bottom that there are a number of other tests that are working their way towards getting information down towards that 3-hour period. I'm not going to go into these in detail, but you may in your laboratories have the BioFire test, which I know that in the last 1 to 2 years came out in our laboratories without a lot of fanfare. And I would like to have learned more about its release. And the BioFire is a test that's being done with cultures to identify the organism early on from the culture growth. So it's a PCR-based tool and has a whole array of organisms. And that I heard at Olympic Medical Center, they had just started using it, and that may be available to you guys as well. Other things for improving early diagnosis include, I mentioned neutrophils earlier. Well, there's a large number of tests looking at even single cells, looking at a behavior to see if they are going into a sepsis state that can be then recognized as the patient having sepsis. These two papers just highlight that machine learning models and artificial intelligence are trying to be applied to the whole EMR and identify patients in basically in subgroups of who are at higher risk to see if that can help identify the patients who go on to have sepsis, and you can focus awareness or treatments on that subgroup. And I point out this last one, which was a external validation of the EPIC sepsis screening tool. EPIC had an in-house tool that they were putting forward in the last several years that had their own proprietary components, but they suggested that it could alert physicians and others to patients' risk of sepsis in the near future. Those models are from EPIC and from other groups are currently being worked on. Unfortunately here, and with a lot of them, they found that the sensitivity was not good when it was in the hands of a team that wasn't EPIC, and it led to alert fatigue with too many alerts. So I'm going to move on from that. There's a lot of things coming down the pike in terms of sepsis identification, and I think it will be interesting to see the combination of, I think, laboratory tests and machine learning type tools to guide our identification. Moving on to antibiotics. This was a key component of the Infectious Disease Society of America's position statement. They are, as always, concerned about excess use of antibiotics, but they also make this statement. It's not just about the risk of having new resistance patterns develop or more resistance, but also there's actually harm to patients when excess antibiotics are given. So they cited studies where among undifferentiated patients with pneumonia or sepsis, broad spectrum regimens, including agents active against MRSA, were associated with higher mortality, particularly among patients without MRSA. So there's risks inherent in overtreatment. The basic dogma for sepsis, septic shock, is that let's get the antibiotics in as soon as possible. Within 1 hour has been a more recent goal. And this is the list of papers that the Soil Sepsis campaign put out in the guideline, which support the idea that delays in time to antibiotics is associated with increased in-hospital mortality. They point out that this data is strongest with patients in septic shock rather than just sepsis. And they have responded to concerns raised with this new paradigm for how they want to think about the approach to starting antibiotics. If shock is present and sepsis is either possible, probable, or definite, any of those groups certainly try to treat within 1 hour. If shock is absent, if sepsis is just possible, but not necessarily probable or definite, I know that's easy at the bedside to figure out, right? Then they suggest that we should have rapid assessment of other causes, non-infectious causes, as well as infection, and hesitate before starting antibiotics, but they still put out the 3-hour goal. So this is a subtle shift from trying to do all antibiotics early, as they say, conflate the shock patients with the just septic patients, and try to allow for physicians in the hospital or in the EDs to have support to do that pause and determine if antibiotics are determined needed. They also this year provided a little bit more guidance on when to start MRSA and fungal infections, and continued with the guidance for risk for multi-drug resistant gram-negative organisms. The premise is that we should always identify if this patient is a high risk for the organism. If they're not, then avoid using that therapy. And they present some of their lists of what constitutes a high risk patient, and I'll briefly show those lists. With regard to the gram-negative rods, 2 agents should be used if patients are at high risk for a MDRO type organism. And this is something that I've taken to heart, because one of our patients from the Peninsula during the Delta phase was an Indian person who had returned to India for a visit, and came back, had Delta COVID infection, ended up in our ICU, and developed a VAP secondary infection, and did very poorly. And we have been treating with broad spectrum antibiotics, Zosyn. We have not seen Zosyn resistance commonly in our antibiogram. And this patient turned out to have resistant organisms, and unfortunately didn't do well. So we did not take into account where he had been and the risk for that organism. Fungal infection, similar idea. So here are their lists that they provided. I'm not going to spend much time on it. but those can be found to help guide when empiric treatments should be begun before identifying the organism. Another important point is shorter antibiotic courses are as effective as longer duration in most cases that have been studied, and they list those cases, a lot of the studies there in a table. Another way that should be somewhat routine, I'm sure you guys are doing it, but doing a molecular or culture screening, nasal, for presence of MRSA to help guide early cessation if MRSA is not present. And this is well supported to be a safe process to back off on vancomycin or linezolid or another MRSA treatment if the presence of MRSA is not there and they don't have additional risk factors for having MRSA. Another measure for trying to shorten antibiotic course length is the use of procalcitonin, and they do not promote screening for infection with procalcitonin, but they are in favor of using it as a biomarker to discontinue antibiotics, and they cite meta-analyses to support those views. And not a change, but should be mentioned that as part of overall treatment with antibiotics and going after infection, we have to get source control, and they recommend within 6 to 12 hours. So we do have to call people at night to go place drains or open up abscesses to and not put those treatments off. Going to move on to fluids. It looks like I am nearing 45 minutes, so I'm going to continue to move fast. Please interrupt if there are any things that you have questions about. They have moved the 30 cc's per kilogram recommended fluid amount to a weak recommendation from being a strong recommendation, acknowledging that there's really not good evidence for that particular amount. The amount has never been studied in a randomized type trial, but there's evidence in observational retrospective analyses to show that when patients get less fluid, that there is increased length of stay and increased mortality. And in this particular study they cite, they say regardless of whether CHF and ESRD is present. And that remains a difficult topic for many of my colleagues who are in the emergency department because they are worried about excessive fluids in those patient populations in particular. But the Surviving Sepsis campaign is sticking with that amount, saying at least that amount should be given, but it's a weak recommendation. And just a note, the early goal-directed trials process, Rise and Promise, they all used, on average, around 2.1 liters in that initial bolus, somewhere in the range of 30 cc per kilogram, which is also supportive of that data. When it comes to type of fluid, last time I did this talk a couple of years ago, the movement was certainly towards the balanced fluids. And in 2016, the Surviving Sepsis campaign said you can use either. This last year, they're saying we suggest with a weak recommendation that you should use the balanced fluids, highlighting the single center studies from Vanderbilt, SALT, which are called SALT and SMART, which showed a benefit if you combine the outcomes of mortality and kidney injury with the balanced fluids over saline. And they did highlight in this guideline that there are ongoing trials to inform future updates. One of those trials was actually published in January of this year in the Journal of Medicine. And it was a large trial, New Zealand and Australia, 53 ICUs, 5,300 patients, all critically ill, randomized to either what they call BMES, balanced multi-electrolyte solution, which was plasmolite or saline. And in the box at the bottom, you can see that many patients had sepsis, around 42%. And the upshot here was that they didn't see any difference in survival at 90 days. They didn't see a difference in kidney outcomes either. And for the sepsis subgroup, there was really no difference. On the same date, New England Journal of Medicine, another component, also published a systematic review and meta-analysis. Here they took 6 of the 13 randomized controlled trials, the ones that had low risk of bias, 34,000 participants. This included the patients in the New Zealand and Australia studies. And they had this conclusion, which I'm going to read, and you have to bear with me. It's a very statistically correct conclusion. The estimated effect of using balanced crystalloids versus saline in critically ill adults ranges from a 9% relative reduction in death to a 1% relative increase in the risk of death, i.e., could be helpful, but there's also a chance that it may be harmful, with a probability, and this was their Bayesian interpretation, that the average effect of using balanced crystalloids is to reduce mortality. So I'm still advocating for balanced, and with a little bit less fervor. I guess there's one more big study out there, but I think we're safe to say that using either one is probably okay. What about the volume of fluids in that first 24 hours? In the Process, Arise, and Promise trials, they used about 7 to 8 liters in the usual care group. However, there's no good data for surviving sepsis campaign to make a statement, and they cite their ongoing studies, Clover's trial, Classic trial, and happy St. Patrick's Day. Hope you enjoyed it yesterday. The Clover's trial, we do have somewhat of a result, and I'll just say, unfortunately, it doesn't really provide us great guidance, but I'll briefly comment on this trial. Clover's took patients who were in the emergency department, had septic shock, and had received up to 3 liters, and at that point, randomized them to either early vasopressors for continued management of shock or liberal fluids. And they were able to separate groups out into getting a lot of fluids or less. The trial started in 2018. They were going to enroll 2,300. After 1,500 patients were randomized, a scheduled DSMB review found that the outcomes remained similar in both arms, and that further enrollment was unlikely to change the result. The study was halted. The final reports haven't been published. He said there's no safety concerns regarding patients in either arm, but there was unlikely to be benefit. So I look forward to seeing how much fluid was actually given in the liberal group. But this, I think, can be interpreted to say it's safe to start vasopressors early. And there may be, we still don't know what amount of fluid is unsafe in resource plenty population. What about those early vasopressors in the Surviving Sepsis campaign this year? They did endorse the use of peripheral vasopressors with statement that it does lead to faster hypotension resolution and that rates of complications were low. They cite this study, the Sensor study, which was randomized patients to an early set dose of norepinephrine versus standard of care, which demonstrated improved control of shock at an earlier time point and a trend towards improved mortality. And then a systematic review is supportive for the use of peripheral vasopressors. Yes, extravasations do occur, and in this population of 1,300, happened 3.4% of the time, not insignificant. But there were no reported episodes of tissue necrosis or limb ischemia. I think we'll start to see more data on this to confirm that it is safe. But this has been very helpful, I think, in our ERs for getting things started and not delaying on hypertension. They still endorse using dynamic fluid responsiveness testing, and this year also pointed out that capillary refill time has recently been validated in a study as to be as good as, or maybe even better than serial lactate in identifying patients who have poor tissue perfusion and need further resuscitation. Closing in towards an ending here, I'm going to quickly go over these last few. Hypofronasal cannula, the Oscars are coming up, so I gave them the Life-Saving Achievement Award because I think its role in the pandemic has been huge. I certainly prefer it over non-invasive therapy for trying to keep patients off ventilators and not introducing the lung injury that may happen to patients on non-invasive ventilation where you can't control volumes as much. In sepsis, studies have shown that it is preferred for associated hypoxemia and lung injury. Steroids got a bump this year, and cirrhotic sepsis campaign from weak quality of evidence to moderate quality of evidence. They were a star of the pandemic as well. They recommend a dose there when the vasopressor equivalent dosing is at around 60 micrograms per minute of norepinephrine. And there was data to support those trials. Unfortunately, vitamin C is not panning out despite the fanfare around the vitamin C steroid confinement study that came out from a single center with incredible and maybe not believable results. Follow-up studies showed that high-dose IV vitamin C has not been effective in improving sepsis outcomes. So if we reflect back on our patient, certainly she presented with shock, should have had antibiotics much earlier. The lactated ringers versus saline, in my mind, less of a question at this point. And before I thought certainly we should focus on lactated ringers. Excessive fluids, now we still don't know. It sounds like we are okay with early vasopressors and that the fluid amount may not be as harmful, but we'll wait to see what the Clover's trial did in terms of how much fluid. In her case, she developed severe ARDS, and no one sure is whether that was partly due to the amount of fluid. Dynamic fluid responsiveness should certainly be used. Safety in using early vasopressors peripherally. More endorsement for steroids, and looking for risk factors to prevent sepsis. It's something that we should always think about, and vaccinations for asthmatic patients remains really important. I showed you this slide earlier, and I will just, looks like I'm at 54 minutes. These are things we're working at in our house. We're doing process measures. We're focusing on patients, not just with sepsis, but with shock. So we're going to do our process measures in-house on the sickest patients and make sure that we're doing the best care for the sickest, and hopefully that will translate into best care for everyone. And I'll just end here. Clinicians really want to deliver excellent care, best in class. They see right through efforts to pad the E. They recognize the harms of recipe-driven medicine, such as antibiotics in the waiting room, just to check a box, even though the administrator is not able to measure the harms. Clinicians believe they're already delivering excellent care in most cases. They'll try to wiggle out of metrics unless they participate in creating the cohort and have opportunity to dialogue in the making and with reviewers. So we need buy-in at all levels. When we're instituting our changes, we need meaningful data and learn from our mistakes. I'm going to throw up here the Pacific Northwest Sepsis Conference poster that's happening in June. I spoke with Dave Carlbaum yesterday. He's very happy that this could be in person and online. And one of the speakers that will be Sean Townsend, who is part of the controversy around step 1 at this time, and I look forward to hearing from him. Thank you. I'm going to stop there, and I think I saved a few minutes for questions, and I don't think I see any in the chat. So please speak up if you have any.